Hello, my name is Kaylee Acosta. I'm a student physical therapist from the University of St. Augustine for Health Sciences. Thank you so much for taking the time to listen to my presentation today. I'd like to present you with a patient that I recently evaluated who is experiencing long history of low to mid back pain. And according to Franca et al. From the Journal of Manipulative and Physiological Therapeutics in 2012, low back pain affects nearly 50% of the general population and is defined by back pain lasting longer than 12 weeks. The purpose of this presentation is to lay out the possible tissue impairments that could be correlated with function and if they might be contributing to the patient's low back pain. So a little bit about my patient. The patient is a 22-year-old female grad student with an ectomorph build. She was diagnosed in grade school with adolescent scoliosis of the lumbar spine, ICD-10 code M41.126. According to medicalnewstoday.com, for approximately 80% of people who have scoliosis, the condition develops without a cause or reason, also known as idiopathic. My patient participated in multiple sports per year, year-round, throughout high school and college, and she thinks that highly contributed to her back pain because it was much worse during that time. Her complaint today is soreness and fatigue in her low to mid back after standing or sitting for long periods of time, and she usually notices this about 2 hours in. When the pain gets very bad, her pain is dull and achy, and it travels up to her lower thoracic region. The numeric pain rating scale was used to quantify this patient's pain. It is a scale from 0 to 10, 0 being no pain at all, and 10 being worst pain imaginable. It has excellent reliability and validity and was endorsed by Bajor et al. In the Academic Emergency Medicine Journal of 2003. So this patient rated her pain at best a 0 and at worst a 7. And then as I was doing the evaluation, it was about a 4. So things that make her pain better are laying down and resting in supine position and then stretching and using heating pads. Things that make it worse are standing for long periods of time or sitting, and then other activities such as hiking or anything that requires focus of the body for longer than 2 hours. When she first wakes up in the morning, she doesn't notice any pain. Over the course of the day, however, her pain does increase. But if she does go to sleep with pain, she does not wake up with pain. An outcome measure that I had her fill out was the Oswestry low back pain questionnaire. This was validated by Fairbank et al. In 2008, and it showed to have extremely high reliability and validity. The patient scored a 12%, which correlates with a minimal disability. There were no red flags for this patient, and then her past medical history, she had no prior history of PT, but she did have a history of chiropractic. So she did say that this actually made it better. She goes to see a chiropractor around 4 times a year. The patient stated her goal was to learn to move better without back pain and then healthy pain management. So some of the tests and measures I performed during my examination were structural analysis. I noticed forward head posture and rounded shoulders. Her upper trunk was slightly rotated to the right, and her left shoulder and hip were higher than her right, and her belly button was slightly to the left. I did notice a leg length discrepancy, so I measured from the ASIS to the medial malleolus, and I found a 1-inch difference from the left to the right, the left being longer. And then from the left, I noticed a good kyphotic curvature and lordosis of the of the lumbar spine. But then from the right, it looked like her spine was relatively straight. From the back, I noticed a visible scoliosis curving to the left, which is known as levoscoliosis, in the lumbar and thoracic spine. And then I noticed a rib hump on the right. Her AROM, her forward bend and side bend right was full with no pain. Her side bend left was reduced around 25% with deep pain in her low back on the left. Her right rotation was 25% reduced with no pain, and then her left rotation was reduced by 50% with no pain. Her back bend was excessive with pain only felt at the L4, L5 interspinous space. So upon palpation for condition and palpation for tenderness, I noticed increased tone throughout thoracic and lumbar musculature, more so on the right, and then tenderness noted with moderate depth palpation in the L4, L5 interspinous space. For her PROM, there was muscle guarding and feel of the lumbar musculature paraspinals during all of the following passive intervertebral motion tests. So I noted hypomobility when checking flexion and right rotation of T10 through T12, hypermobility of L1 with flexion, hypermobility of L2 with flexion, and then pain during right and left rotation of both segments. And then hypomobility during flexion of L4 through S1, and normal mobility with rotation to the left, but pain of L4 and L5. Or sorry, just L5, not L4. She was negative for her neurovascular screen. And then the lower quadrant screen, I noted her hip internal rotation on the left was 20 degrees, and on the right was 26.5 degrees. There was no pain with these, and then all other measurements were unremarkable. Her manual muscle strength testing was weak for the hip abductors and for the transverse abdominis muscles. I did special tests, and they were negative for all SI joint issues. And then she had a positive prone instability test, and that is characterized by, it's a test that predicts the patient's success with a lumbar stabilization program. So the patient is prone with legs off of the table, feet resting on the floor, and the therapist applies pressure on each vertebral segment in the posterior to anterior direction. And if there is pain at one of those segments, then the patient will lift the feet off of the floor. And if the pain decreases with a retest, then the test is positive. So my patient was positive for that. And then I checked for aberrant motion with any active movement, and I did see some of that. I saw some minor muscle spasms and increased tone through her paraspinals. And then I applied an axial load on the top of her shoulders in standing, and I did see also spasms and increased tone during that. All other lumbar special tests were unremarkable. So my clinical impression with this patient is, according to Rabin's clinical prediction rule, if the patient has aberrant motion present and positive prone instability test, they would benefit from the lumbar stabilization exercises. After a full examination, I concluded that this patient has a minor instability problem along with muscle guarding from long-standing back pain, and would likely benefit from stabilization exercises. My PT diagnosis is low back pain with movement coordination deficits, and that's ICD-10 code M53.2. My interventions and impairments are as follows. Muscle guarding of erector spinae is my first impairment, and the intervention would be soft tissue mobilization to reduce muscle tonicity and guarding. A study directed by Churkin et al. In 2018 by the Physical Therapy Research Journal found almost an immediate reduction in pain and an increase in functional capacity following superficial soft tissue manipulation. And the patients were able to tolerate more activities after this. My next impairment was hypomobility of T10 through T12 and L4 through S1. My intervention for that is manual mobilization. Joint mobilization techniques have been proven to reduce pain and improve segmental, spinal, or lumbopelvic mobility in individuals with low back pain in a study done by Delito et al. In the Journal of Orthopedic Sports Physical Therapy in 2016. For the hypermobility of L1 to L2, I used strengthening for the transverse abdominis and lumbar multifidus as my intervention. Franca et al. Published in the Journal of Manipulative and Physiological Therapeutics in 2012 that exercises were proven to help stabilize hypermobile segments of the lumbar spine by strengthening deep trunk muscles, such as the lumbar multifidus and the transverse abdominis. So for the weak hip abductors, my intervention was strengthening those. Jean et al. From the Journal of Physical Therapy Science published in an article in 2015 explaining the results of a study that showed that patients suffering from chronic low back pain recovered faster when they incorporated a hip stabilization program. My prognosis for this patient is excellent. The patient is a young, active individual with no comorbidities and is ready to employ an exercise regimen. The long-term goal we decided on was in 6 weeks, the patient will increase muscular endurance and decrease her pain to be able to tolerate classes that last longer than 2 hours. So a brief summary of my patient. Based on the recent findings from clinical and epidemiological research article written by Hoy et al. In 2017, low back pain is the leading cause of activity limitation and work absence throughout much of the world and is associated with an enormous economic burden. However, low back pain does not need to limit you from participating in activity. By incorporating strengthening exercises and for supporting musculature, the patient should be able to bounce back better than ever. I want to thank you all for listening to my presentation and open the floor for any possible questions you might have. Thank you.